Chow, are you ready? Yeah. Good morning, and welcome to the San Francisco Planning Commission and Health Commission special joint hearing for Thursday, September 6, 2018. I would like to remind members of the public that the commissions do not tolerate any disruption or outbursts of any kind. Please silence your mobile devices that may sound off during these proceedings. And when speaking before the commissions, if you care to, do state your name for the record. I'd like to take roll for the Planning Commission. Commissioner Fong.
Here.
Commissioner Johnson.
Here.
Commissioner Koppel.
Here.
And Commissioner Moore. We expect Commissioners Hillis and Richards to be absent today and Commissioner Melgar to arrive shortly.
And I'll be taking roll for the Health Commission. Commissioner Chow.
Present.
Commissioner Lois.
Present.
Commissioner Green. Commissioner Sanchez. Commissioner Bernal.
Present.
Very good. Commissioners, you have one item under your special calendar for case number 2012.0403W, the California Pacific Medical Center Annual Compliance Statement. This is an informational presentation.
Thanks. Could I have the overhead, please? I'm sorry, not the overhead, the projection. Good morning, President Chow, Commissioners. I'm Elizabeth Pearl, Planning Department staff. The item before you is an informational presentation on California Pacific Medical Center's compliance with their development agreement for the 2017 reporting period. This is our 5th annual reporting period. I'm joined by Mitchell Griggs of the Health Service Systems, Ken Nim of the Mayor's Office of Economic and Workforce Development, and Sneha Patil of the Department of Public Health. Today's hearing is one part of the annual review process required by the development agreement. The DA requires CPMC to submit an annual report on compliance and for the city to evaluate their compliance and hold this public hearing. Following this hearing, the directors of Planning and Public Health will determine whether CPMC is in compliance with their obligations for last year. A third-party monitor will review the director's findings and inform the Board of Supervisors whether he agrees with that determination. CPMC's development agreement allowed them to build a new hospital and medical office building at the Van Ness and Geary campus, formerly called Cathedral Hill, with the requirement that they also build a new hospital to replace St. Luke's. The development agreement requires that the replacement St. Luke's Hospital be opened within 2 years of opening the Van Ness Hospital. In fact, Sutter met this commitment with the opening of the Mission Bernal Campus Hospital last month, well ahead of schedule. The DA also requires Sutter to make payments for a range of public benefits and improvements. In 2017, Sutter was required to make 3 payments for a total of $7.1 million, all of which were paid, and that completes their payment requirements under the development agreement. Sutter's total payments to date have been over $73 million. Construction of the Van Ness Hospital is now well underway. It's expected to open in 2019, and the associated medical office building will also open in 2019. CPMC regularly provides the required schedule updates through their website. Future construction will include the new medical office building at Mission Bernal once the old hospital is demolished, and improvements around the Mission Bernal area, including the planned Guerrero Park upgrade, which is due in 2019 as well. For the 2017 reporting period, there are 11 main action items up for compliance review, as shown here. These include payments, hiring commitments, healthcare commitments, public improvements, and community outreach. My colleagues will go into many of these in greater detail. One reporting area, the local hiring program, has a reporting period that does not correspond to the calendar year. So that means that we'll be able to provide you with more recent information on that than on other topics. And Ken Nim from Workforce will explain how CPMC's overall hiring record compares to the goals in the DA. One additional obligation under the development agreement is the limit on fee-for-service increases by CPMC in its role as a provider for the city's healthcare services system. Mitchell Griggs will provide an update.
Good morning, Commissioners. Mitchell Griggs, Chief Operating Officer and Deputy Director of the San Francisco Health Service System. In late March of 2018, Milliman provided the analysis evaluating increases between calendar years 2014 and 2015, using data from January and December of those years. CPMC was in compliance. Per agreement, Milliman reported that CPMC had satisfied the annual rate increase commitment of the increase to be less than or equal to 5%, but no additional details were provided other than the methodology used for the analysis. CPMC and San Francisco Health Service System has agreed to engage Milliman to conduct two separate analyses, evaluation comparing calendar year 2015 data to 2016 data and comparing 2016 data to 2017 to determine year-to-year rate increases. San Francisco Health Service System requested the claims data from United Healthcare and from Blue Shield of California for 2016 and 2017. Milliman has received the claims data from UHC, and we are expecting those results in about 8 weeks. Thank you.
Thanks, Mitch. And now we're going to turn it over to Ken Nim of Workforce.
Good morning, Commissioners. Thank you for having me here today. My name is Ken Nim. I manage the compliance program at the Office of Economic and Workforce Development. My Workforce Director, Joshua Arce, apologizes he can't be here personally to thank you for all the support that you've been providing us in order to make this program successful and getting local residents to work on the project. So first, before I start, I'd like to acknowledge Emily Chea and Lowell Rice of my office. They're the ones that's in the grounds doing the work and getting people to the jobs. And of course, without the support of Herrera Boat, we have Paul Klemish and Joanna Leva that's been in the ground and really forcing the contractors to ensure that we have the hiring goals met. It wouldn't be successful. And of course, Varam from CPMC. So that's my acknowledgement. Now, the first goal is hiring at least 50% of new entry-level positions for non-union administrative positions. So we exceeded the goal, 32 out of 37, which is 86% of the applicable participants got on the job, and some of these jobs are particularly lead document coordinators, accounting clerk, project administrator, project management, and even the safety coordinators. And these were hired through our CAPSA program, which stands for Construction Administration Professional Services Academy. This is separate from our regular construction academy that we host every year, and it's specifically focused on these administrative positions. So the project have exceeded the goals. Now, moving on to the next, which is hiring interns. So 56% of the interns were hired, and we worked really closely with the Unified School District, San Francisco State, their MESA program, which is the Mathematics, Engineers, Science Achievement, really focused on economically disadvantaged students to get these opportunities. And of the 29 interns, actually 10 were hired full-time with the contractor on the project. So this was very successful in making sure that students graduating from our schools get the opportunity to work on the project. Now, the next slide, and actually the third and the fourth slide, are the challenges we've been experiencing, and this is specifically focused on construction. First, on the hiring goals for entry-level union apprentices. At least the goal is 50%, and we've reached 30%. Although it's below the 50%, Herrera Boat and the contractors really worked with our system, particularly our City Build Academy and our community-based organizations that we recruit individuals to get into the industry to get them to work. To date, of the July 2018, we've had 168 resident apprentice construction workers that was placed on the project. And some of the challenges we've been experiencing is actually getting available local residents interested in some of these higher skilled craft. For example, the drywall lathers, iron workers, sheet metal workers, bricklayers, operating engineers. It was very difficult to fill these positions. We get employers that request for these workers, and working with the unions and the trades and all our community-based organizations, we were able to get some workers in there, but still wasn't enough to reach the 50% goal. And I'll address a little bit more of the details of why in the next slide, which is our fourth goal, reaching a 30% overall hours for journeymen. And apprentices would be performed by San Francisco residents. As of the July 2018, we've reached 25%. Of the 5 million plus hours, 1.2 million were performed by local residents. The biggest challenge is the Bay Area, specifically San Francisco. We've had a boom in construction all across the city. City Build had been involved with all the major construction work. And in the last several years, there was unprecedented demand for local construction laborers across the region. And this impacted CPMC's contractors to achieve the minimum 30% goal. And compared to this same reporting period as last year, we've actually increased 1.8 million work hours, which is about 36% of increase. And keeping it at 25% was, to our end, was very successful in working with the contractors to make sure that they fulfill their commitment. And also at the same time period, City Build have been working with the Chase Center in building the Warriors Arena, the Salesforce Tower, all these other major infrastructure. A lot of work hours were added into those work, and they were pooling local residents to make sure they had their own local high requirements that they had to meet, and they were competing against each other for our workers. So, but still, we've had more than 309 resident construction workers placed throughout the workforce system on this project alone. And some of the things that City Build have been doing to meet the demands of the industry, last year, we increased from our regular 2 cycles of City Build Academy training, we increased to 3 additional specialized training. This year alone, we've already increased to 5 specialized trainings, just this year alone to meet the demands. And one of those examples was the Chase Training Center training that happened, graduated last week. 32 out of the 32 participants graduated and are in line to work on the construction of the Chase Arena. And in addition to that, we have the Glen Eagles training program, and all this efforts to make sure that we don't leave anyone behind. Even though we are economically in a vitality with 2.1% unemployment rate, we want to make sure the communities that are still challenged with unemployment to get the residents to work on not just this construction projects, but across the in San Francisco. All right. And these are just some additional information for your reference. These are the demographics in pie chart, where, as you can see, with the work hours and how many of that is apprentice compared to the rest of the work hours. And now we break it down by demographics of the neighborhood it represents. And one of the neighborhoods that we really target are like the Bayview, Hunters Point, Ingleside, Inner Mission, Excelsior, and those are a lot of representation from residents coming into working on this project. Now, in addition to our workforce development, I'm here also to speak on behalf of the CMD Contract Monitoring Division. The contracting goals have also been met. So the main goal for the LBE participation is at least 14% of the contractors working on the project are local business enterprises. And some of the specific success, Van Ness had 15%. The medical office building currently have 12%. The St. Luke's, which just celebrated its grand opening, is at 21%, and all 3 projects combined is at 16.4%. And through July 2018, about more than 225 million revenues have been generated for local businesses. And specifically outside of construction, we also have opportunities to work on the operations of the hospital. So this is entry-level positions. It could be medical clerks and working in the hospital's operations for the food industry. So a lot of those jobs are entry-level, which our goal is for 40%. And I'm happy to report that it's exceeded, and these are some of the target areas that we worked with. So Western Addition, Chinatown, Outer Mission. And currently we're at 54%, so 35 of the 65 employees were hired through the workforce system. And in addition to the workforce hiring, there's also investment fund grants that was provided. CPMC paid over $3 million to workforce fund administered through the San Francisco Foundation and also in partnership with the Office of Economic and Workforce Development. The fund focuses on barrier removal, job training, and providing employment opportunities. So our office works closely with the local community-based organizations to make sure that they get the funding that they need to provide the services that are needed for residents to get through some of their barriers to work on the project. And it also targeted educational institutions and nonprofit organizations with priorities in the priority neighborhoods. Some of the current grantees are FACES SF, Jewish Vocational Services, Self-Help for the Elderly, Success Center, and Young Community Developers. And that concludes my portion, and I'll be around to answer questions. Thank you.
morning, Commissioners. My name is Sneha Patil, and I'm with the Department of Public Health, the Office of Policy and Planning. For this section of the presentation, I will be providing an overview of compliance related to the healthcare commitments within the development agreement. So this slide provides a summary of the healthcare commitments within the development agreement. There are multiple provisions related to healthcare which are intended to ensure that CPMC continues to provide high-quality care to all San Franciscans, especially those who are low-income, Medi-Cal, or uninsured. So as I mentioned, this slide is a summary of those commitments. The first three provisions have multiple commitments. So there are 5 baseline commitments to maintain the same level of charity care, 3 provisions to increase care to Medi-Cal beneficiaries and low-income individuals. There are 2 provisions on the Innovation Fund, which totals $8.6 million to fund community-based services and programs. And finally, there are an additional 5 healthcare provisions that range on various topics around subacute care to culturally and linguistically appropriate services. And so the next slides will provide more details on each of these commitments. So this slide shows each of the 5 baseline healthcare commitments, CPMC's 2017 performance, and a determination of whether CPMC is compliant on each. So starting at the top, in the past few years, CPMC has exceeded the development agreement requirement of caring for 30,345 charity care or Medi-Cal patients. Charity care refers to health care provided to those who cannot afford to pay without the expectation of reimbursement. In 2017, CPMC cared for 39,569 unduplicated charity care or Medi-Cal patients. The second provision is related to community benefit, which is unreimbursed costs that CPMC incurs to improve community health. In 2017, CPMC exceeded the $8 million community benefit requirement and provided about $12.5 million. CPMC has met this requirement by providing grants, including community health programming and community outreach. I just want to note that these first 2 requirements are also verified by Deloitte as a third-party audit. The third and fourth provisions are related to charity care policies. So the third provision was in effect until 2017, which was that CPMC was to maintain their current charity care policies. That obligation was met by the end of 2015. The fourth provision is that CPMC maintain charity care policies that are compliant with the state law, and that is the case. As of 2017, CPMC's charity care policy was the same as it was in 2015. The last provision is for CPMC to continue to support Bayview Child Center. Since the ownership has transferred to the South of Market Health Center, CPMC has provided an operations grant for 5 years, invested over $1 million, transferred assets, and is still serving as the clinic specialty and hospital partner. So the next 3 provisions focus on Medi-Cal, which is public insurance for low-income San Franciscans. So the first provision, CPMC has continued to participate in Medi-Cal managed care with the San Francisco Health Plan. The next provision requires CPMC to assume responsibility for 5,400 new Medi-Cal beneficiaries, and this obligation was met in 2014, and CPMC continues to meet this obligation. In 2017, they had a total of 32,739 beneficiaries. The third requirement is that CPMC serve 1,500 of new Medi-Cal beneficiaries through a partnership with a Tenderloin serving primary care provider that is able to contract with managed care, Medi-Cal managed care. Currently, there is no such provider, and so to meet this obligation, CPMC has partnered with Northeast Medical Services to bring in St. Anthony's Clinic as a primary care provider in the Tenderloin. At the end of 2017, there were 170 members enrolled through this partnership. CPMC has reported that they are continuing to work with St. Anthony's leadership to develop a path towards sustainability and to support outreach efforts. A grant of $35,000 was awarded to St. Anthony's through the Innovation Fund to help increase capacity to do outreach. So there are two provisions in the development agreement that pertain to the Innovation Fund. The first is that CPMC is to make payments between 2013 and 2017, totaling $8.6 million. The final payment of $1.125 million was made in 2017, and this completes their obligation to the Innovation Fund. The second provision describes how the funds will be used, and they are administered by the San Francisco Foundation. So CPMC, along with the Department of Public Health and the San Francisco Foundation, sit on a committee to grant awards that support community clinics, behavioral health, and other community-based services and programs that ultimately support the health of San Franciscans. In 2017, the committee granted awards totaling near $700,000 to 6 different organizations. So the remaining healthcare provisions in the DA are standalone and again span a range of topics. So the first provision on this slide requires that CPMC develop specific proposals to provide for providing subacute care services. So subacute care services are a form of skilled nursing care in which patients require a higher level of care than your average person in a SNF. And so the requirement was that CPMC present these proposals to the Health Commission. This obligation was completed in 2016 through a presentation of the Post-Acute Care Project report to the Commission. The second provision is around the integration of staff across CPMC campuses. In 2016, CPMC completed this integration of St. Luke's medical staff into a single integrated staff at all 4 campuses. With the completion of the new hospital campus, CPMC also plans to integrate that staff. The third provision requires that CPMC participate in a community benefits partnership, and they have continued to do so through participation in the San Francisco Health Improvement Partnership, which is a cross-sector initiative that consists of San Francisco nonprofit hospitals, UCSF, community-based organizations, the Department of Public Health, to improve the health and wellness of San Franciscans. The next commitment is for CPMC to continue their partnership with Chinese Hospital. CPMC has maintained agreements for covered California, commercial HMO, and high-risk OB-GYN populations. I know in the past there were some concerns about this negotiation in late 2016, but ultimately CPMC and Chinese Hospital settled on a renegotiated agreement which satisfies CPMC's compliance for this provision. The last provision is on national cultural and linguistically appropriate services, or class standards. CPMC has reported that it is their policy to deliver services in accordance with the mandates of these standards. And though CPMC is compliant with this provision, commissioners and community members have expressed concerns in the past regarding the cultural and linguistic appropriateness of CPMC services, particularly at the St. Luke's Diabetes Center. So to address these, DPH and CPMC met in April of 2016, and the meeting resulted in specific recommendations to increase Spanish-speaking staff, to provide Spanish group classes, hire reception staff, and collaborate with Health First program. For the 2017 compliance review, CPMC has provided updates and has reported that they have maintained several of these recommendations. And so this concludes our report on the specific development agreement provisions for the 2017 year. I will note that with the opening of the Mission Bernal campus, additional healthcare provisions are now in effect and will be reported on in the 2018 year. For example, that includes that CPMC maintains services at its Mission Bernal campuses and create 2 centers of excellence in community health and senior health. So you'll hear more about that at the next review. So this last slide, I just want to take a second to highlight a few of the key healthcare issues that have come up previously. So the first, again, is just related to cultural and linguistic appropriate services at the St. Luke's Diabetes Center. So CPMC has reported progress on these recommendations during 2017. They have maintained Spanish language staffing capacity by hiring a 0.8 FTE Spanish-speaking registered dietitian and certified diabetes educator. They've offered Spanish language classes, which began in August of 2017, and they've continued to collaborate with the Health First program and Diabetes Center. CPMC did not hire reception staff, which was recommended, but has continued to monitor patient access through a question on the bilingual satisfaction survey. And in their 2017 data, they reported that 92% of patients did not feel that access was limited by not having a reception area. The second item on this slide is shifting of services from CPMC, outpatient services from CPMC to Sutter Pacific Medical Foundation. Through the Health Commission's Proposition Q process, CPMC has informed the Commission of plans to transfer management of 5 outpatient clinics, including the St. Luke's Diabetes Center. So the Health Commission has already held a hearing on this and will continue to deliberate and assess whether this transfer will have an impact on continuity of coverage for patients. The third issue is related to the closure of St. Luke's SNF and subacute SNF. I understand that this was also discussed at previous hearings, and so I just wanted to provide an update. Again, subacute care is a type of skilled nursing care that is for medically fragile individuals. And in 2017, CPMC announced that they were closing St. Luke's subacute and skilled nursing unit. And so that unit did close in 2018 with the opening of the Mission Bernal campus, which is resulting in a 68% reduction in overall SNF beds at CPMC. However, following hearings at the Board of Supervisors and the Health Commission in 2017, CPMC did commit to continue to care for the remaining subacute patients. And I believe as of August 2018, the remaining subacute patients have been transferred to their Davies campus. And so that concludes this portion of the presentation.
As you've heard from my colleagues, Sutter Health is generally in compliance with the requirements of the CPMC development agreement, although there are ongoing areas of concern that include enrollment with the Tenderloin Medi-Cal managed care provider, culturally and linguistically appropriate services, and construction hiring of union journeymen and apprentices. The information we've received so far for 2018 indicates continuing compliance. Staff's recommendation to the Directors of Public Health and Planning is to find CPMC in compliance for the 2017 reporting year. Staff will be available for questions after CPMC's presentation, and now Jim Maksud of Sutter Health is going to make that presentation briefly.
Thank you so much for your help. Good morning, Commissioners. I'm Jim Maksud from Sutter Health's External Affairs Group. Thanks for having us here this morning. I'm joined by some colleagues who can serve as subject matter experts when I'm sure we get into a question and answer portion of this morning's hearing. We're pleased to be here today. As you've heard, we've opened the new Mission Bernal campus on the 25th of August. You're looking at baby Isabella, who is the first baby born at the new Mission Bernal campus. Everything there with patient census appears to be steadily increasing, and satisfaction from staff and patients alike. So we're very happy to have a successful opening underway. This is photos of the Van Ness campus, which is on track to open March 2nd and 3rd of 2019 is when we'll transfer patients from the Cal and PAC campuses to that new location. We have been awarded approval to staff and stock, so we're getting our training schedule ready, and a little later on in this fall, we'll begin training at the new Van Ness facility. These are photos of the Van Ness MOB, which went up much quicker than the hospital across the street. Even still, with some tenant improvements that are going on, it looks like the MOB might open just a bit later than the hospital, maybe the end of March. Maybe if we can squeeze that schedule in the next 6 months, it'll open at the same time, but right on schedule. We showed this last year just to make kind of a overarching view of the major transitions that we see. We're counting this as kind of 4 major transitions, and with the opening of Mission Bernal, we've accomplished one of those, which is to move services from St. Luke's and a few services from PAC and Cal to the new Mission Bernal Hospital. As I said, in March, number 2 will be opening Van Ness. Number 3 will be the Van Ness MOB, And then number 4 will be kind of once that situation has settled, we'll resort a few programs and services that have had to move to temporary locations while construction was being finished, and that will take us to 2020. Something we've talked a lot about in these hearings in the past is community engagement. And last year, we wanted to make sure we showed the broad range of community engagement that we're involved in, not just certain specific conversations. We wanted to continue sharing that view with you here today. There's a couple things specifically I'd like to call out because we actually haven't included them in the past. One is that first point, that in 2015 we established a buy local program in the Lower Polk neighborhood. We've talked a lot in these hearings about the neighborhoods and activity around the Mission Bernal campus, maybe not so much about our activity and community engagement around the new Van Ness campus. This is a program we're very proud of, worked with our partners on, and it's been ongoing since 2015. So we wanted to make sure to include it here today. I also would like to point out the Sunday Streets program, if any of you are familiar with that. This will be our 4th year of participation with Sunday Streets, which means throughout the entire year in 10 neighborhoods across the city, we're there talking to the people that are coming to the events, asking or getting their input, answering their questions. It's a very grassroots level of community engagement that we've had ongoing for years across the whole city and wanted to make sure that we pointed that out to you today. We also, it was mentioned, the Guerrero Park project down by the new Mission Bernal campus has generated a lot of community interest and activity in helping the design partners determine what that park was going to look like. And then the last thing would be to just note that we had a very lively, exciting public block party the week before the new hospital opened, and we had more than 500 community members come out to kind of kick the tires, if you will, on the new Mission Bernal Hospital and take a tour. It was a terrific event. This is also a slide that you've seen before. This is a running total. And where we are now through July 2018, the total impact to San Francisco from this effort has crossed the $300 million mark. It's something we're proud of and something we hope that the commissioners and the writers of the development agreement also take some pride in seeing this investment into our community. 2017 accomplishments and 2018 key priorities, of course, we're happy to be found in compliance on all commitments. I wanted to note a few things here rather than run through this entire list. We continue to work in good faith and have exceeded the operational workforce hiring goals. That is a tremendous amount of effort in conjunction with OEWD and others, and we do have subject matter experts here from our team who can answer specific questions about all the outreach they're doing and the amazing commitment to accomplishing those goals. The transportation subsidy, we are continuing to promote that. It is just one piece of our commitment to reducing our single occupancy vehicle rate. We're increasing by at least twofold the amount of on-campus transportation fairs that we hold. We have many partners there, so that, again, the subsidy is just one part of the options that encompass our transportation demand management program. And again, we have a subject matter expert here, Rigo, who manages that work and can take you through the amazing activity going on there. We lastly hope to stay on track for the March opening of the hospital and the medical office building. And then I think I will just proactively say, as I assume it will be a question coming from staff's key health issues for us to follow up on or watch. The transfer of service of the St. Luke's Diabetes Center to the Medical Foundation, SPMF, the benefit that actually brings is that there's a receptionist. So the first healthcare priority that was noted has actually already been solved. That receptionist speaks Spanish. The secretary in the office who sits right behind that receptionist also speaks Spanish. And the MA in the program speaks Spanish and is in the midst of getting her Spanish certification. So healthcare items 1 and 2, as noted by staff, the transfer of that service to the Medical Foundation has already accomplished some improvements that we've been talking about for a couple of years. And that concludes our comments. And again, we're here to answer any questions you might have. Thank you.
Thank you. Is that it for staff presentations? Yes?
I understand that the Coalition of San Franciscans for Healthcare, Housing, Jobs, and Justice has requested some time to address the commissions. Is that correct?
Yes, we can do that as part of public comment.
Yeah, that concludes the staff presentation. We'll be available for questions afterward.
Okay, thank you so much. So with that, I'll open it up for public comment. I do have some speaker cards. Julie Villa Roman, Joan Zhang, Dina Lowe, Larry Liu, and Steve Forney, and Thomas Kravick.
Commissioner, my understanding was that an arrangement was made to...
Indeed. In the past, we've afforded them 10 minutes as organized opposition.
Okay, go ahead.
Thank you very much. Good morning, commissioners and directors. My name is Ascanio Piamelli. I'm a professor at UC Hastings College of the Law and director of the Community Economic Development Clinic, which represents San Franciscans for Healthcare, Housing, Jobs, and Justice, the community labor coalition that pushed the city to insist on all of the community benefits that we're hearing about today. For the 5th year in a row, the coalition submitted written comments on CPMC's self-assessment, and my understanding is that staff have included those comments as the last item in your packet. The coalition continues to urge the commissions and directors to use this compliance review process not simply as a yes-no box-checking exercise to bestow the passing grade on CPMC that we all know CPMC will be awarded. Rather, we encourage you to use this public process to insist that CPMC and city departments answer some important questions outlined in the coalition's written comments, which I will summarize momentarily, and coalition members will expand upon in their public comments. For some of these issues, we ask you to look more closely. For others, we ask you to take a broader look. And of course, coalition members and I are happy to respond to any questions that you have after public comment. So let me just preview the 7 areas that we'd like you to look further at. The first has to do with charity care patients, and here we're asking you to take a closer look. Yes, CPMC is exceeding the numbers of patients that it's committed to. There's been a great deal of volatility from year to year. We think it would be helpful to ask why that volatility. It would be also informative if we knew a little bit more granular detail on charity care patients. At which campuses are they being seen? What zip codes do they come from? How many are receiving full services? How many are just one-time diagnostic appointments? In an era of electronic record keeping, those are not difficult questions to answer. The second issue has to do with the St. Luke's Diabetes Center, which the health department has noted as one of its key healthcare issues. And the key question there, after CPMC fired its bilingual, bicultural staff 4 years ago, is has there been a diminution in access for the historically monolingual Spanish-speaking population that it served? CPMC has not provided, the city report states that CPMC hasn't provided the city with information to answer that question. We don't know how many monolingual Spanish speakers were being served in 2014, how many of them are being served now. That's a question that the public deserves an answer to. The third issue that we would invite you to take a broader look at is CPMC serving frail and elderly patients the way that we in San Francisco would expect a well-resourced, state-of-the-art healthcare organization to do? The Health Commission has heard about the actions at St. Luke's with the SNF, at Swindell's, and we would encourage you to use this as an opportunity to get an understanding of whether CPMC really believes that its treatment of frail and elderly patients is the best that it can do. Fourth issue has to do with a Center for Excellence in Senior Care. On that point, I will distribute a written statement from Dr. Ken Barnes that outlines the coalition's expectations for what a Center of Excellence should look like. The fifth issue, also identified by the health department, has to do with the commitment to serve 1,500 residents of the Tenderloin on Medi-Cal managed health care to provide specialty and hospital care to those patients. In the city report, it indicated that only 180 Tenderloin residents have signed up. Today's presentation said it's actually only 170. For several years, St. Anthony's has been given funds from the Innovation Fund to do recruitment. The coalition has suggested on a number of times there are additional steps the city's public health department can take and CPMC could take in order to publicize the availability of those services, perhaps to provide transportation if that is the impediment that is leading people not to choose the St. Anthony's NEMS managed service organization. The sixth issue is in the realm of entry-level operations hiring, where it is entirely correct more than 40% of the hires are coming from the First Source hiring program. But the way more important, closer look that we would urge you to take is why have the total numbers of entry-level hires plummeted 74%, from 220 hires in 2015 to 57 in the city report, now 65 in the presentation today. And why did CPMC project that it would hire 3 times as many entry-level operations hires? And perhaps even most importantly, what are the retention rates of the people that are being hired through the First Source hiring programs? These seem like really reasonable questions to ask, but neither CPMC has provided the information, nor has the city apparently requested it. And then finally, the seventh and last question that we'd ask you to inquire about is what is CPMC doing to promote the public transit subsidy program to its employees, to get more than 18% of its employees to take that public transit subsidy when 43% of its workforce live in San Francisco. So with the commissioners and directors' permission, I'd like to hand out a summary of those questions and the coalition's written suggestions for what a Center for Excellence in Senior Care would look like.
Thank you very much for your comments.
Thank you. And we also have a number of
If you could
speaker
hand
cards
those,
to
please.
submit.
Those in. If folks want to make comments on this, please come up, the names that I've already called. If you have not turned in a speaker card and you want to comment, if you could line up near the wall on my left. Thank you. Come up, please. First speaker, come on.
Good morning, Commissioners. My name is Jen Zhang, CEO of Chinese Hospital. Chinese Hospital is a small nonprofit community hospital located in Chinatown, offering a wide range of medical services to a multicultural community for over 100 years. Our clients are mainly low-income Asian immigrants. Many of them are monolingual seniors. Over 91% of our patients are Medicare, Medi-Cal, or uninsured. The existence of Chinese hospital is crucial to the communities it serves. And Chinese hospitals' OB services flourished through the years with over 50,000 births recorded. And then I have a display that kind of showing you that in 1998, limited by only being able to provide level 1 labor and delivery services, so Chinese hospital partnered with the CPMC and relocated its labor and delivery services along with its nurses to CPMC to provide the community direct access to both primary and tertiary OB care. So CPMC also agreed to charge Chinese hospital and its affiliates reasonable market rates according to the CPMC development agreement. We respectfully ask the commissioners to help facilitate that Sutter keeps the reasonable market rates, which are consistent with the CPMC development agreement for Chinese hospital and its affiliates. And my colleagues will talk about some of the rate changes. Thank you.
Thank you. Next speaker, please.
Good morning. My name is Julie Villaroman. I have a few papers that can be handed to everyone. I want to thank you for letting me speak today. I just want to read a letter that was written for us. I'm a licensed vocational nurse at CPMC. I work postpartum labor and delivery the last 14 years and have been an employee for 26 years of CPMC. On February 16, 2011, I received a letter after we were beginning negotiations. It said, "Dear Julie, during last year's collective bargaining sessions with SEIU, UHW, we discussed CPMC's plans to rebuild our facilities in San Francisco. Your union representatives recognized the importance of those plans, but they were concerned about what might happen to your jobs when the new facility opens. We understand those concerns and agreed to a very strong employment security language in your contract. I'm writing you today because there is some confusion exactly about quotation employment security means. It's simple. All SEIU representative regular employees who are employed on the date of your contract was ratified March 18, 2010, will continue to have jobs at CPMC when the new facilities are built. So if you worked at CPMC back in March and are still working for us when the new facilities open, number one, you are guaranteed employment with the same or greater pay than you will be earning then. And number two, you will have no reduction in hours unless you ask for a change. Also, CPMC has no intention to interfere with your right in union representation. Again, thanks for your hard work and dedication. Werner Brauner, MD, MPH, CEO. I am here because as of August 29th, I was asked to go into a conference room with management and basically stated that LVNs across the board will no longer have jobs as working on the unit. I have dedicated our time as speaking before all the LVNs, 4 of us who work postpartum labor and delivery, that we are excellent nurses. Although we do not carry certain job engagements of the RNs, we are able to give great care to our employees and to our patients. We are great colleagues. We have worked very hard in our profession, and we deliver the highest care given. In the second and third page, I have letters from management, letters from a patient, which I can give more of, and also a survey that was done by Truvenin of 3,000 hospitals, basically stating that I'm incredibly proud that this is the second time you've been recognized as a top performer on Truvenin's 15 top healthcare systems, and I'm so grateful for your dedication and partnership.
Thank you, ma'am. Your time is up.
Thank you very much for listening to us today.
Thank you, Ms. Villarroman. We appreciate your comments. Next speaker, please.
Good morning, commissioners and directors. My name is Dina Louie, and I am the current and new CEO of Chinese Community Health Plan, aka CCHP. CCHP administers contracts on behalf of Chinese Hospital. Thank you for the opportunity to address the Joint Planning Commission and Health Commission. Per the CPMC development agreement, CPMC was supposed to continue to provide services in a manner generally consistent with existing services agreements with Chinese Hospital and its affiliates as of the effective date of the DA. I find it difficult to accept that CPMC/Sutter is providing services in a manner generally consistent, quote unquote, when Chinese Hospital has experienced exorbitant rate increases since 2013, as my colleague Larry Liu will attest. My apologies to both the Department of Public Health and to the commissioners that our contract and rate issues were just in the last few weeks shared with the Department of Public Health. Chinese Hospital and its affiliates respectfully encourage the two commissions to request that Sutter Health Corporate act in the spirit of the DA and engage in upcoming 2019 rate negotiations that result in reasonable market rates for Chinese Hospital and its affiliates. We request this in the spirit of cooperation amongst local providers, the only standalone community hospital in San Francisco, and the only one-ish of two remaining San Francisco-based commercial health plans in serving San Franciscans. Thank you for your time and attention.
Thank you, Ms. Louie. Next speaker, please.
Good morning. My name is Larry Liu. I'm the COO of Chinese Community Health Plan, and I was born at Chinese Hospital. As CCHP provides the administrative services for all the managed care patients for Chinese Hospital. The spirit of the development agreement and the past relationships with CPMC and Chinese Hospital were collaborative. CPMC provides hospital services for the community which are not available for Chinese hospitals, such as labor and delivery or pediatric beds. In mid-2014, just a few months after the development agreement was concluded, Sutter notified us that they were terminating all of our existing contracts with CPMC, St. Luke's, and its doctors, and demanding much higher rates. During our most recent contract negotiation, Sutter again insisted on rates that were more significantly higher than our own costs and the market as a whole. Just to put that in perspective, the cost of a normal delivery at CPMC is now 2.5 times what it was in 2013. So, as you may know, CCHP is one of the plans that serve individuals in San Francisco who qualify for subsidies through Cover California. So these higher costs get passed on to members through their higher premiums and our higher costs when they get care at CPMC. So we hope that you will hold Sutter accountable to the spirit of the development agreement, more importantly to the collaboration that we had prior to 2013, and return to more reasonable and fair market rates for their services. We believe this will help us fulfill our mission to provide quality, affordable care to the communities that we serve. With that, I'd like to thank you for the opportunity for giving you comments, and thank you for your important work.
Thank you, Mr. Liu. Next speaker, please.
Good morning, Commissioners. Thank you. My name is Dr. Tom Kravis. I'm the Medical Director of CCHP, and I live with my family here in San Francisco, less than 20 minutes walk to Chinese Hospital. Our son has selected his own personal physician who is on the staff of Chinese Hospital, and although he receives many of his services there, he is referred for certain specialized care at CPMC. For an office worker in his 20s, the cost of care at CPMC, including the out-of-pocket co-payments and deductibles, is high. His needs are a microcosm of the problems that thousands of our senior frail elderly face because they have multiple chronic conditions which often require specialized services at Sutter, where the cost of care is high and certainly considerably higher than Chinese Hospital. Studies published by UCSF and other reliable sources over the past several years have shown that the cost per hospital admission is higher by about 113% when the care is provided in large systems such as Sutter. Let me be clear. We acknowledge that the care at Sutter is medically appropriate and of high quality. However, let's ask ourselves this. How many of our thousands of members that average 74 years of age were aware that a simple agreement entered into years ago about OB care and care for babies could have such an adverse impact on the cost of their care, and that today that same or similar care at Sutter may cost them considerably more than at Chinese Hospital? We remain committed in having our member, just as we would our families, to receive the highest quality care. However, let us see how we can work together going forward to make this care more affordable. We respectfully request that there must be a thoughtful consideration of the intent of the agreement with Sutter and the significant financial burden on families today. Thank you.
Thank you, Dr. Kravis. Next speaker, please.
Good morning, Commissioners. Thank you for the opportunity to speak today. My name is Stephen Forney, and I am the Chief Financial Officer for Chinese Hospital. I've only recently taken that position. I am honored to be able to work with such a vital part of the San Francisco community. As mentioned by previous speakers, Chinese Hospital's relationship with CPMC is longstanding and an integral part of its continued mission to provide high-quality, affordable health care to its community. Maintenance of that relationship in a generally consistent manner was central to the CPMC development agreement. Unfortunately, the rates paid to CPMC under that relationship have not, in any meaningful definition of the sense, been generally consistent. We find them today at an increasingly high level that is far beyond the market rates paid to other providers in the market. Consequently, we are in a position of not being able to sustain that level of payment to them, and we ask the commissioners to help us in upcoming negotiations to restore that generally consistent premise that was originally intended under the development agreement. Thank you.
Thank you, Mr. Forney. I'm going to call out a few more speakers. Bob Prentice, Michael Lyon, Melanie Grossman, Jane Sandoval, and Mary Michelucci. If you're already up here, please just come up. Next speaker, please.
Good morning, Commissioners. My name is Javier Bramond, and I work with Community Housing Partnership, and I'm also a representative of the Good Jobs for All Coalition. I want to first acknowledge that Sutter CPMC has, at an aggregate level, been having success in hiring economically disadvantaged workers by the city's First Source hiring program for entry-level positions. We would like to note, however, that Sutter CPMC, and echo what has been noted before, that it has had a glaringly decreased its overall entry-level hiring. And we urge the commissioners to explore the reasons behind this dramatic slowdown. And as what was noted before, we also urge the commissioners to ask how many of the entry-level operations hires over the last several years have been retained. In addition, and we think this is very important, that there were 6 targeted neighborhoods in the development agreement. And if those targeted neighborhoods are not being reached, we should have them be identified so that this can be addressed. Although progress has been made, such an extreme shortfall from overall predictions warrants a deeper explanation. Thank you very much.
Thank you. Next speaker, please.
Good morning, Commissioners. My name is Kong Fang. I'm the Executive Director at Jobs with Justice San Francisco, and we're also part of San Francisco's for Housing, Healthcare, and Justice. So, as we have spoken here, when we look at development in the city, and especially CPMC, one of the biggest promises, right, has been jobs for the members and residents of our city. I think that promise has not been fulfilled. When we look at the PowerPoint where it said the operational workforce hiring goals were exceeded, Well, if we sidestep that, it's not operational, but it's construction. Those goals have not been met. Where the target was 50% of city-referred applicants, only 30%. So that's clearly a goal that we need to reach and still fulfill. And what Javier mentioned, when we look at the actual number of jobs that were delivered to the people who need it most in our city, we are falling short. So in CPMC's own 2016 compliance statement, there was a projection of 173 entry-level jobs. That is far short of what actually happened in 2017. So when we look at that, 33 of the jobs were city-referred of the entry level. And that actually, if we think of 173 entry-level jobs that we were hoping for, 40% of that target would be about 69 jobs. So in terms of the actual number of jobs that came through, 33, that's about a third. You can check my math on the papers. But just as you can see, right, when we dig into this a little bit more, right, there's a lot of work that we need to do. And I hope that the commissioners can really inquire, what is the reason between this shortfall? And another important piece of context is the first 2 years in 2014, 2015, CPMC did not meet its goals. It was at 0%. It was at 22%. So your work as commissioners, our work as the community is so important for our community to actually reach its hopes of having fulfilled good employment at CPMC. Another thing that I want to point out was in 2014, CPMC did provide retention data. And that's something that we hope for looking back into 2017 and looking to next year, that we really need this retention data, right? It's not only enough for our community members to get in the door, they need to be able to stay. And so in a booming economy, right, we have to really look out for who is being left out and how do we bring them in. Thank you.
Thank you, Mr. Fang. Next speaker, please.
Oh, this is a timer? Oh, 3 minutes. Whoa. Okay. My name is Bob Prentice. I represent the Bernal Heights Neighborhood Center on the Blue Ribbon panel to consider the future of St. Luke's, and have been involved with the coalition since its inception. But today I'm actually going to read some testimony that Dr. Ken Barnes had prepared. He wasn't able to make it today, but Dr. Barnes practiced for over 30 years at St. Luke's and was involved in the early days in the Save St. Luke's Coalition and has been part of our coalition. I won't be able to read it all, even with the 3 minutes, which is generous. But in the discussions we've had so far in the Senior Center of Excellence at St. Luke's Hospital, it has revolved around centrally the Acute Care for the Elderly, or ACE program, which is for hospital-based seniors, which we think is a good program. And it is certainly consistent with the development agreement. But I want to pick up Dr. Barnes's testimony where I think we're talking about trying to expand that vision. And I'll just read it. So the ACE, he said, such a program is envisioned by CPMC as for hospitalized older adults. Well, this is commendable and something we support. We believe you must first ask what is the purpose, goals, and scope of such a center. The vision goes much deeper. Providing seniors the whole range of services from primary care to specialty care, skilled nursing after discharge from the hospital, both community and hospital-based, access to RCFEs, or residential care for the elderly, and access to adult day health care. Such clinical services should include health promotion and disease prevention, engaging the senior population as partners in efforts to improve their overall health and the health of the community. Seniors need to be supported in their residences so that they can live full lives as healthy and productive as possible. It's crucial that the transition from the hospital to residence be done with sensitivity and skill, and that the overarching goal be the maintenance of seniors in their residence, also known as aging in place. For this to happen, such a center must be linked to community support programs, which means the center has to have deeply rooted relationships with the community organizations that provide such services. There need to be interdisciplinary teams in both the hospital and the community which meet regularly and provide continuity of care, as well as active support as patients transition from one level of care to another. And to accomplish these goals, there must be community accountability, and CPMC should want to accept input about the needs of the community through the establishment of a community advisory board for the center. This is our vision, and we hope that you and CPMC share that vision so that the center can be built into a thriving entity with patient-centered care as its hallmark. Thank you. Sorry for reading, but that's what I had to do.
Thank you, Mr. Prentice and Dr. Barnes. Next speaker, please.
Michael Lyon, and I'm also with the Coalition for Jobs and Justice. San Francisco has real health problems. There's a 20-year gap in life expectancy between the rich and the poor areas. There's too many hospitals in the rich areas, but only 2 in the poor areas. There's a shortage of skilled nursing facilities, and there's a bad shortage of mental health and substance abuse treatment. Why are we even dealing with private healthcare giants like CPMC in the face of all these problems? These so-called nonprofits which make hundreds of millions of dollars and give very little to the poor. These chains that gobble up hospitals, clinics, and physician practices in order to establish monopolies and jack up their prices. These hospitals that proudly announce that they'll push high-paying services and eliminate poorly paying services regardless of the patient's needs. How will CPMC deal with the poor? It's simple, get rid of them. Sutter CEO Mike Cohill told the supervisors, quotes, "The new St. Luke's will serve a new demographics that is better insured, better employed, and better educated." Why else would CPMC eliminate Spanish-speaking clinicians and receptionists in the diabetics unit? Why else would CPMC locate its Valencia and 20th Street clinic in an expensive residential building? Why else would CPMC drop the name of St. Luke's Hospital with its associations with Black and Latin working-class patients? We need to go way, way beyond the development agreement to see whether CPMC is fulfilling its obligation. And we demand that CPMC, the private hospitals, and the city itself provide equal, affordable, accessible, and culturally competent health care for everyone.
Thank you, Mr. Lyon. Next speaker, please.
Thank you, Commissioners, and good morning. My name is Melanie Grossman, and I am a licensed clinical social worker specializing in geriatrics. I represent the San Francisco Older Women's League, and we are a member of the coalition. Generally, a center of excellence is defined as a comprehensive program in a particular medical area which supplies concentrated expertise, best practice care, education, and other services. CPMC's vision of the Senior Center for Excellence serves only hospitalized patients with access to the new ACE unit. Language in the development agreement leaves ample room for something much broader. Our vision would offer inpatient and outpatient whole person care, which means care of physical, mental, and cognitive health, caregiver support, and programs promoting independence and reduced social isolation. To ensure aging in place, the center would work closely with community resources and families to make timely and culturally appropriate referrals. A referral to Meals on Wheels fails if there is a 3-month waiting list and no follow-up. Our center would not be organized top-down, as the current center is. Community input is essential. I worked on developing the Always Active program in San Francisco. We started with focus groups, interviews with agencies, churches, and stakeholders. Always Active is still going strong all over the city because of community input. Also stipulated in the development agreement is a Center of Excellence in Community Health, mandated to screen and manage individuals with or at risk for chronic diseases, building on the existing Health First program. We need more than an extension of what already exists. This is an opportunity to build something truly excellent that will serve as a model for other hospitals in the city. CPMC needs to do more than satisfy the minimum requirements of the development agreement. Otherwise, the two centers of excellence become nothing more than empty political and marketing tools.
Thank you, Ms. Grossman. If the next speaker could come up while I call off a few more speaker cards, please. Debbie Perkins Coloma, Elizabeth Wheatley, Teresa Palmer, Paul Cartier, Julie, that she already spoke, Elizabeth Cronin. Hello, thank you.
Good morning, Commissioners. Thanks for the opportunity for us and allowing us to speak. My name is Jane Sandoval. I'm a staff nurse at CPMC St. Luke's, now newly dubbed Mission Bernal campus. I've been a staff nurse for 33 years, also on the Board of Directors of California Nurses Association. Nurses began meeting with CPMC officials before the opening of the Mission Bernal campus with concerns about safe staffing. We expected that CPMC would be able to provide us with detailed information about their staffing plans for each of the hospital units. CPMC admitted that plans for the units were fluid and unknown up to the very moment of the opening. Up until this week, they were unable to provide us with staffing plans for the hospital. This should be elementary and should have been done long before now. After all, we knew when the hospital was opening. We had a countdown clock in our lobby and by the cafeteria, so we knew when the hospital was going to open. It wasn't new. It didn't just happen. From our vantage point, we had to fight CPMC just to keep from closing St. Luke's. I've been testifying here for 10 years about keeping St. Luke's open. It's not new. Since then, we've fought their plans to shut down vital services such as SNF and subacute. It's more than ironic that they boast about their center of excellence in senior care after removing the very units that would help our aging patients transition from hospitalization. And it's very nice that they had a catered affair and a block party with very Instagrammable moments, but at the end of the day, we have patients to take care of, and the hospital needs to be adequately staffed. We ask that the commissioners hold a special meeting focused on the transitions to the new hospitals with a focus on patient safety practices, including safe staffing for the transition period and beyond. Thank you.
Thank you, Ms. Sandoval. Next speaker, please.
Good morning. My name is Mary Michelucci. I have worked at St. Luke's for 44 years. I retired this year, but I'm still active in our nursing union. Currently, I would like to talk about the obligation for local hire and the responsibility CPMC has for that. Unfortunately, we have traveling nurses or contract workers at St. Luke's Hospital. Regular staff nurses are told to stay home. The traveling nurses are working. Yesterday, on the telemetry floor, 3 of the day shift staff nurses were told to stay home, and the travelers worked. What does this mean for us? It means that the orientation process possibly is happening for the traveling nurses, but not for the regular nurses. My concern is the financial impact it has on these nurses. These are absent days, they're not paid days. I would like to see CPMC honor the contract it has with the nurses that it hired and be less focused on installing traveling nurses in vital positions that should be staffed by nurses that they've hired years ago. I think traveling nurses should be an addition to, not a substitute for, regular staff. Thank you.
Thank you, Ms. Michelucci. Next speaker, please.
Good morning. My name is Deborah Perkins Kalama. I am a registered nurse at formerly the Cal campus and the orthopedics unit. Only a few weeks before the opening of the new Mission Bernal Hospital, which I prefer to still call St. Luke's, we discovered that our unit, where we care for post-surgical patients, would be moving to the new campus. It's shocking that after many years of this entire process, CPMC would determine in the 11th hour. I mean, we had about 8 weeks notice that we were going to move into the new hospital. Our training took place in a rush. We had 6-day-a-week work weeks because of our training. We were going from training up back to the hospital, so we were working 16-hour days. The planning was non-existent. In addition to that, the doctors who normally also bring their patients to our previous unit were not notified. Many doctors had no idea up to the time we closed that unit on 1 East that we were going to be moving away, and they had no places to put their patients. Doctors were not afforded the courtesy of being notified ahead of time, and now HR is scrambling to try to get doctors to move to Mission Bernal so they can fill those beds. In numerous meetings with CPMC over the weeks since this news came to light, nurses have repeatedly made the case, given this poor planning, the hospital should patients first and staff up during this transition period until the dust settles. However, we've staffed up for 1 week, and now we're going straight on regular ahead. It's been incredibly disruptive. It's an unfortunate indication of a lack of serious patient-centered planning on the part of CPMC. We urge the commissioners to hold a special meeting to discuss the important matters of patient safety that emerge in the midst of these hospital transitions. Before CPMC repeats the same mistake in the opening of Van Ness, Sutter needs to plan ahead and anticipate the effect of these moves on the patients and its staff. For an example, we were told by HR that there would be no impact of the move of our unit to Mission Bernal. However, now the nurses on 4 North and 5 North of the Pacific Campus have a lower patient census. They're losing shifts. They essentially are losing jobs by losing shifts. Let me see. I had a couple more comments. No, I guess that's it. But it's chaos, and CPMC deserves to treat their patients better and deserves to treat their staff better. And we don't want to see the mess that we've seen at Mission Bernal occur at Van Ness. Thank you.
Thank you, Ms. Perkins-Coloma. Next speaker, please.
Good morning. Thank you for having me here. My name is Elizabeth Wheatley. I'm a registered nurse in the telemetry unit at St. Luke's Hospital. My primary concern as a nurse is the safety of my patients.
Speak into the microphone, please.
Sorry. My primary concern as a nurse is the safety of my patients. It's CPMC responsibility to ensure that the staffing of the hospital meets the highest standards, to ensure that I can carry out my role as a caregiver. It was our hope that CPMC would have executed a safe and smooth transition to the new St. Luke's Hospital, given the many years that have passed between the adoption of the development agreement and opening last month of the new building. I'm sorry to say that has not been the case, and it's my hope that the opening of the Van Ness campus in the spring will not be a repeat of what we have recently experienced at St. Luke's. We expected that CPMC would listen to the nurses and suspend their usual practice of ultra-lean staffing for a generous period of time while caregivers adapted to the new hospital, which its many layers of changes from our previous environment. Instead, CPMC staffed up the new hospital for only 1 day or 2 before reverting to their usual pattern of cancelling nurses from our shifts at every opportunity, leaving those of us who worked short-handed and scrambling. Moreover, they sent permanent locally hired staff home while retaining subcontracted temporary traveller nurses. We've been scrambling for needed medical supplies and learning to utilise new technologies with frequent glitches, all whilst juggling full patient assignments. This was unnecessary and unsafe, and the result of nothing more than CPMC's grim obsession with the bottom line, coupled with dismally poor advanced planning. Given CPMC's history of slashing needed services for ageing and vulnerable patients, such as the recent closure of the hospital-based SNF and subacute units at St. Luke's, it's discouraging to imagine CPMC presenting itself as a beacon of care before this hearing. CPMC must do better for San Francisco. Thank you.
Thank you, Ms. Wheatley. Next speaker, please.
Hi, my name's Dr. Teresa Palmer. I'm a geriatrician, and I work with the Coalition for Housing, Healthcare, Jobs, and Justice. In the 2017 report, Sutter ignored its obligation to care for 1,500 Tenderloin patients on Medi-Cal. Also, as in previous years, Sutter provides a confusing aggregation of numbers about charity care with inadequate breakdown of the services provided and the population served. The aim of the DA was for Sutter to collaboratively care for lives in the Tenderloin, not to just give isolated single services. Sutter CPMC is non-compliant with these service and reporting requirements. The DA asked Sutter to act in good faith to develop solutions for the subacute SNF bed shortage in San Francisco, specifically considering that Sutter shutting down the subacute SNF unit at St. Luke's left San Francisco with no subacute beds. In addition, the progressive shutdown of hospital-based SNF beds, most recently many by Sutter, has crowded long-term care patients out of town, leading to a worsening critical shortage of nursing home beds all over San Francisco. Sutter's participation in the Northern California Hospital Council's post-acute care study was supposed to satisfy its obligation to find solutions. It absolutely did not. This study examined how hospitals could avoid losing money on difficult patients, but did not address the crisis caused by the serial shutdown of hospital-based subacute SNF and SNF beds in San Francisco. Sutter is non-compliant in its obligation to make a good faith effort on the subacute SNF shortage. There is room in the planned medical office buildings on both sites and the 30-bed shell at Van Ness to add post-acute SNF and subacute SNF care. However, Sutter CPMC is really only interested in getting rid of services that don't generate sufficient profit. They don't care what the people of San Francisco need, and they don't care what old people need. Sutter is marketing the Mission Bernal Center of Excellence while abandoning needed services for seniors in San Francisco on all levels. This includes adult day health care, residential memory care, post-acute SNF care, and subacute SNF care. Sutter has no mechanism for substantive input from the community, such as a grassroots community advisory board in the neighborhood surrounding St. Luke's. Their actions at open streets and are just marketing efforts. There's no good faith way for the communities to give input to Sutter about what they need. Thank you.
Thank you, Dr. Palmer. Next speaker, please.
Hello, my name is Paul Cartier. I'm a resident of San Francisco for 40 years now. I walk, I bicycle, I ride public transit, Muni, BART, Caltrain, and I drive. Since we have an ongoing problem with traffic, I'm thankful that I have a variety of options on how to get around the city and beyond. I am very concerned about Sutter Health's lack of compliance with important parts of its transportation program. The main concern here is that Sutter Health is doing very little to increase the number of employees utilizing public transit, which they estimate from an online survey at 25%, as compared to 55% in single-occupant vehicles, SOVs. Meanwhile, they are positioned at the nexus of two major Muni transit corridors, notably the BRTs. This is a little paraphrase from Exhibit K in the development agreement. CPMC shall encourage all employees, new and existing, to enroll and purchase a Clipper card as a part of its transportation demand management plan. As part of its normal TDM activities, CPMC shall promote the use of the subsidy of the Clipper card, undertaking additional outreach as necessary to drive up adoption and achieve the SOV reduction goals. None of this is mentioned in the current compliance report. Currently, Sutter is passively promoting by signs in cafeterias or inserts in new hire packets. By actively promoting the advantages of using public transit and regularly subsidizing the Clipper card, Sutter Health could become a good corporate citizen. They could also be in compliance with Transit First and environmental goals. Moreover, the Clipper Card program can track its actual use by its participants and Sutter Health's progress in promoting this use. Otherwise, all we have is the say-so from a survey of some portion of its busy employees. Thank you.
Thank you, Mr. Cartier. Next speaker, please.
Morning. My name is Elizabeth Cronin. I'm a nursing assistant at CPMC Davis Campus. Last year, August 30, we have an arbitration hearing, and the judgment went on December or January of this year. It's because of the short staffing that we're getting through the years. And part of the staffing guidelines, they're not complying in it. And as a 5150-seater, the judgment of that is all the seater cases has to be a 5150. It means it's not deduction to the floor staff for the CNA on the floor. But until now, CPMC is not complying on that arbitration guidelines that we won on that hearing. And until now, they're taking out the seater. Every time we have a seater on the floor, they're taking out from the floor, and it's become the short staffing of the CNA. And it's hard for the CNA that is deducting one CNA on the floor every time we have a seater, because it's burden more on the work for the CNA. Even we don't, by the numbers, when we still have the same patient, but the heart patient is like only with one CNA instead of the CNA, so you're going to have more work and you're going to have more tired, and it's not even safe for the patient or the staff. Thank you.
Thank you, Ms. Cronin. Next speaker, I think I've called all of them. I have Ruth Cativo, Sylvia Aquina, Roel Anastasio, and Ms. Kim Tavaglione. And if I have not called your name, but you want to speak, please come up and come on in.
I work at CPMC back campus, and I'm gonna show you a floor where I work. Oh, shoot.
Ma'am, you'll need to speak into the microphone. Thank you.
Sorry. Okay. This is the hallway, and we have 3 nodes, 4, 5, 6. The total of the beds is 41. And I handle, sometimes when I work at the night shift, we start at 28 patients, but I'm done with 8-hour shift. Sometimes I get 65 patients. Some of them going, when they went down, go to MSICU or die. And I'm the one who's responsible to push in order the bed be open so ER can put more patients on the floor. I have to clean up the dead person and go to the morgue. And that's on 2nd floor. I walk many miles, and my friend, many steps for 8 hours on each node. 2 of the nodes, 10,000 steps, and 13,000 steps on node 6, because it's a little bigger. I'm on my last limb right now. I hurt this one, I hurt my left and my right now. So I hate seeing patients to compromise their daily care. If I found a patient I'm so sorry. I love my patient, and I'm so emotional when I talk about my patient because I'm gonna fight for them. They are my first thing. Every time I go there, sorry, it's my 2 minutes. It's gonna be a little longer. Every time I go there, afraid to angel of God, that there's no, when I go into the room, there's no dead person, and nobody informed me. or someone in the stairwell is dead because they are so confused and they went to the stairwell because they don't know how. Here's the the floor plan. It's really confusing. And I'm by myself on the floor. How in the world I feel like a Tasmanian devil going circle for 3 nodes. That's not fair. And I'm telling you now, I'm on my last limb. So it's the good thing. There's nothing bad thing happen on my ship when I'm 85% by myself on the floor.
Thank you, ma'am.
I'm so sorry, but it's just so hard.
Thank you, Ms. Aquino. We appreciate your comments. Next speaker, please.
Good morning. My name is Ruth Cativo, and thank you so much for this hearing. And I bring a message for my father. He was in St. Luke Hospital in Salvaque area. So you know, guys, that they moving to Davis. I just coming over here because my father is suffering a lot. Because, you know, the nurse, they not prepared for those patients. My father, when there is action to him, most of the time, he always bleeding because they don't know how to do it. And I talk with the nurse and I say, can you please be more human? Because my father, you know, sometimes he cry and sometimes he just close his eyes and do like this because he cannot talk. So I am his voice. That's when I come over here and I bring some picture of him. Please helping us. I want that you please going over there and Davis and check the nurse because, you know, when they come over here, all of them, they talk very well. They say that the nurse, they capable to handle this patient, but they not. Most of the nurse, they don't know what to do. And when we asking them, can you please move my father slowly and human? And you know, they very upset with us when we asking them for a towels because we had to wash my father. You know, they next to Sunday ago, they throwing the towels on my sister's face. And I reported with the nurse that is in charge of the floor. And that's why, you know, I'm here right now because, you know, we tired. My father is suffering a lot. And some of the people over there, they cannot come because they don't speak English. And they say, where we gonna complain when we don't have nobody in the floor? They not talking Spanish, they only English. They are Tagalog, but they don't have anybody in Spanish, only 2 or 3 people. But then they not all the time over there. Please helping us. We need our language. My father needs somebody to talk to him in Spanish because he feels happy. We suffering a lot because, you know, they don't know their job. The nurse, when we're talking to them, they say, oh, you know what, I'm sorry, but they don't training us. We have only a few hours for training, and they throw into the floor to us. This is our job. We have to come over here anyway. But they accepting, some of the nurses, they accepting that they don't have enough training. Please helping us, and don't forget my father. Don't forget all the people that is in Salvaque, Unit, and Davis. And thank you so much, and God bless you. Please don't forget them. Thank you.
Thank you, Ms. Cativo. Next speaker, please.
Kim Tavallone, San Francisco Labor Council. You have a choice today to speak and stand with the community, or you can do the Elmer Fudd thing and follow CPMC. Those are the choices, right? The community has brought up some issues that need to be addressed. The jobs issue, the healthcare issues, what's happening on the subacute, the staffing issues that continue at campuses. All these issues should be sending up red flags. At the very least, abstain from the vote. Don't give them a passing grade until they do better by the patients in the subacute. Not to mention they also closed an Alzheimer's unit at the Cal campus. They have done enough atrocities in the year for you not to give them a passing grade. I think it's about time people stood up to CPMC. They have the resources to fix all these problems, but they choose not to. They rob from Peter and give to Paul, right? They short-staff some units. Clearly, they did not do the training. The health commissioners are aware of this. We've been telling them that CPMC refused to train their Davies staff. It wasn't until after the patients started moving there that they decided to put some program together, some shadow program together. CPMC is capable. They need to do better. You're the ones that can make them do better. So I'm going to urge you today not to give them a passing grade. I'm not saying I don't have any expectations at all that you would say that they're not meeting the requirements, but at the very least, don't give them a thumbs up, because that will be a sad day for the community. That is a sad day for all San Franciscans. And I think the commissions need to stand up to CPMC and say, we know you can do better. Now is the time to do better. We'll come back to you whether or not you're meeting the requirements after you fix these issues. But please stand up for these patients. They need your help, and it's not until you, if it was your family member in the subacute getting towels thrown in their face, would you give them a passing grade? I don't think so. But why does it have to come to that? Why does it have to wait till it gets that personal? Stand up for these folks. That's all we're asking for today. Thank you.
Thank you, Ms. Savaglione. Any other public speakers on this item? Okay, with that, public comment is closed, and we will go with the planning commissioner's comments and questions first, and then we'll turn it over to the health commission.
Thank you.
Fellow commissioners? Commissioner Moore.
May I ask that we hear the Health Commission first? That is their expertise. We are attentive listeners and watchers, and I think their comments, for me personally, are far more weightful at the moment than our own questions.
If that's okay with the health commission?
If that is the wish of the commissioners, we certainly can start on our side. And I'll begin with, we're not used to all this high tech. Commissioners, if you just flagged that you would like to either ask questions at this point of any of the speakers, or to be able to make comments in regards to today's testimony. As you recall, we will not be actually making a decision. The decision is that of the two directors of the departments who will be, in fact, writing a report to the supervisors, which will be reviewed by Mr. Gerardo prior to it going to the supervisor. So there are two different levels. But certainly the input coming from the commissions will be taken into consideration by the directors. And also, these are public issues that, therefore, if the commission, each of our commissions have certain instructions that they would like to recommend to our own departments to look into in order to enhance the development agreement, then those are also issues that we can bring up today and present to our director. So any of our commissioners want to start? Commissioner Sanchez. Not sure. I think you're supposed to push the microphone on button.
Oh, this one here?
Yeah, there you go.
It's really high tech.
Okay.
Is that off or on? It's on?
Yes, it is
Sorry.
on. Thank you.
Well, first of all, I just want to say that I want to thank the departments and both of our commissions for, again, listening to a very formalized report pertaining to the different areas that CPMC has endeavored to bring a number of facilities and patient care up to the standards that we in San Francisco feel must be maintained and increased. as we see even more shifts in our population. At the same time, I also want to comment on the fact that I really think that many of the speakers, in particular, who have been here, some of them have been here for the duration of this inquiry, going back 10 years, to even discuss the fact that St. Luke's would remain in the mission, and there would be an effort to provide the same type of services, including developing some centers of excellence for different populations in different areas. I really thought that one of the most significant outcomes that we heard today, at least in reference to part of the health shifting in our democracy here in San Francisco, is our growing number of elderly and how this is being addressed both by Charity Care, et cetera, in both the Tenderloin and in our own mission district, let's say. But I really think the concepts presented today pertaining to the Center of Excellence that really could anchor down a significant new pathway to provide services for St. Luke's, Burnell Height Mission Hospital could really provide some unique dialogue and some new showcases pertaining to, if it's based on the recommendations and dialogue that both UC Hastings and Dr. Barnes and others have been talking about, and some of our other physicians and patients who have been talking about for years. So I think the department, our department in particular, DPA, really has a unique opportunity to shore in on this and to make sure that these areas are in fact developed and part of the outgoing contribution of this particular effort. The other thing that, as we looked at and heard some of the dialogues pertaining to job training, where they come from. I mean, I was sort of taken aback that, I mean, there's a small number that are from San Francisco, significant, but small number. And the others come from, of course, the Bay Area or East Bay, et cetera, which is fine. But at the same time, you've centered in, and again, that was part of the dialogue before. Let's look at programs in the schools, the MESA program, which has been a flagship program for many minority students in our public schools. But I'm thinking, why aren't we reaching more kids? And again, the community brought this up. Why aren't we reaching more kids and more people in these areas? We are providing basically the zip codes, but we're not talking about where are the kids coming from? What schools are they coming from? Why did they drop out? Why did we have some programs? As an example, you spent almost $8 million, well, $3 million and then $8 million on the others for a number of these job training programs. And then the San Francisco Foundation administered, I guess, the grants for these programs, but some of the grants were not renewed in the Mission District. Why weren't they renewed? Do we need additional training? Is there something we should be looking at? I think you have John O'Connell High School, which is a flagship school, public school. They're dealing with electronics, with computers, et cetera. Here's an area that could certainly be looked at in reference to new pathways in the health sciences. You have a large Native American population in the Mission and other parts here. We have SACNAS, a Society for Native Americans and Chicanos in Science. They've been active for years. Many of them would love to have an opportunity to be involved in things like this. So as a department, both departments look at where is our pool coming from? Are we really providing access? And what about the retention? What happens to those who are hired? Where do they go? Why do they go? Is it just the fact that housing is so expensive? Or do we have families here that are not being involved in this new pathway? And I think it's a great opportunity, arc welding, as an example, I'm mentioning this, I mentioned it a long time ago. There were Native American programs developed for the San Francisco Public Schools and the community college to develop arc welders, the focus on Native Americans because of both culturally and whatever else they had a high altitude prevalence to deal with this type of thing. It worked for at least a year and then 2 years, and they were going to develop more programs in the San Francisco Public Schools, and then they were eliminated because the new arc welding machines had been in the basement of one of the schools and had allegedly been put down as these programs were operational for the Native American school students. And yet when the due diligence people went out to review these programs, these arc welders machines were still in the crates in the basement of one of the schools. So it wasn't even operational. So what I'm saying is that's why we have these commissions to do diligence, to take a look at what really are we looking at pertaining to pool, pertaining to outcome, pertaining to accents, pertaining to retention. Are we providing the highest level of care for our patients? I mean, we have been told, and many times, that there was exceptional community staff planning within the hospital to provide this transition between the whole hospital and the new ones. Then you hear a department is given 2 weeks' notice pertaining to moving patients and units in the new wing. What I'm saying is I really think we need to take a look at how have we been providing this? Are there some areas we could shore up to ensure that patient safety, patient quality care, staffing is adequate to ensure that these services are maintained? Do we need additional training? Do we need additional oversight? Whose responsibility is it? Again, we find these things out when we have hearings like this and listen both to our staff, our staffs, and those who are involved in the scut work of building hospitals and facilities, and our communities who are involved both within the hospital as patients or staff to find out what, in fact, should we be doing. So again, I'm saying that this was a real excellent opportunity to again hear, but not only hear, there is a lot of data we need to take a look at pertaining to are we really making the most significant contributions we can to ensure that all San Franciscans will have the highest quality of patient care in institutions that are accessible, that provide unique models of excellence, and that we have ultimate opportunity for all to participate in jobs and training and retention. So this is a really important meeting. So those would be my questions that our staffs could certainly look at as we go to end our Proposition Q hearings over at the department within the next couple of weeks.
Thank you, Commissioner Sanchez. Commissioner Green?
Well, yes,
Do you have questions of any of the comments?
Yes.
Surely, go right ahead.
I wanted to thank the staff for their remarkable reporting and the insights from the community comments. They were very, very helpful. I am concerned about Chinese Hospital and the Chinese Community Health Plan. I'm an obstetrician at CPMC and work very, very closely with the physicians who deliver patients there. And, you know, I know there's some data about cost of care, at least on OSHPD, that corroborates what's being said here about the contracts. So I think it would be very, very helpful to get some more concrete information from you about the details of what's going on. I think as a staff member and a co-obstetrician, we are very committed to see the pediatric as well as the obstetric services remain robust and the best care possible for the Chinese community. I also am concerned, as Commissioner Sands has said, about transition as someone who will be participating in the transition. In the woman that mentioned about this St. Luke's to Cal campus situation, we found out about it in a meeting when our chair of gynecology had no idea that patients we admit after gynecological surgery would no longer be able to stay on this particular unit she spoke of. Now, that's just one person's experience, but I do think we need a little more detail and a little help on the transition. And then I certainly couldn't say anything more eloquently than Commissioner Sanchez did about our commitment to the quality of care and the availability of care, and how much we really care and appreciate the efforts of both the community members and the staff at CPMC, with whom I work very closely. And I have to say I have the highest regard for your commitment to patient care and for all that you bring to this community. Our nursing staff is absolutely incredible, and we're here to support you.
Thank you. Commissioner Lois.
Thank you to the community, to the hospital, and to all those who spoke today. I have a couple of comments and a question. One of the comments has to do with last year in this room. We spoke to staff from the city side and staff from CPMC, and I asked very specifically, what is the retention data for the population of folk that you employ? And the answer was, well, we don't have that data now, Commissioner, but we will begin the process of collecting that data. Today, the presentation did not have that data. I have some difficulty understanding how we don't have retention data. One of the things that I'm acutely aware of is that when you talk about communities of color and vulnerable communities, access to work leads to access to health care. And if you have those two things together, you improve the mental health and the psychosocial health of those communities. And it's important that CPMC at least help me to understand that that's one of the roles you're taking on. And at this point, I don't understand that to be true. So it's imperative that when we have this hearing again, that you come back and tell me that there are, or tell us, that there are in fact a way of retaining folks and how long you retain them and where they go if they leave the system. Because this is a bottom line issue. Health care and work will help the mental health of traumatized communities of color in San Francisco. And I think we and you have an obligation to make sure that that happens.
Thank you. Commissioner Burnell.
Yes, first of all, I'd like to associate myself with the comments of my colleagues on the Health Commission, and also thank the staff for their excellent work in preparing these presentations and the members of the community who stepped up, particularly with regard to hiring when it comes to the construction trades. Seeing that there is a shortage of workforce in San Francisco, I'd be interested to know what efforts are being made to expand outreach into communities of people who are underrepresented in the construction trades. For example, I didn't see any mention of whether or not there's an effort to increase the number of women who are working in the construction trades, either within any of the data that we've seen or some of the grants that are being provided and the organizations that are being engaged to train and hire folks. So that would be something that I would be interested to know is, are there underrepresented communities that we're just not getting into that could help increase the proportion of not only the construction workers, but the entry-level workers who are both hired and retained? So that would be my additional comment to my colleagues. So thank you.
Thank you. I actually, if I could piggyback on that question in terms of construction, which is a little outside of our healthcare field, but is an issue of the workforce. I mean, there was a pie chart in terms of also the percentages from different neighborhoods. I'm wondering if staff could help us understand why, one, we didn't get the retention information in regards to jobs, and number two, also in terms of the targets and the pies. While you demonstrated how many were coming from different neighborhoods, what were the targets for those neighborhoods? For example, in Chinatown, it says 3% were hired from that community. Was that the goal, and did we do adequate outreach, which I think kind of piggybacks upon the question from Commissioner Burnell. And I don't know if anybody from staff today could actually answer that, and particularly, I think, answer the question from Commissioner Lois, why we did not have retention data that was requested last year by our joint commissions. Is anyone from staff willing to answer that, or they want to?
Come on up, please.
Please.
You, please, on the mic.
Again, good afternoon. Good morning. It's Ken with OEWD. We have Lowell Rice, who's here from our office that works in the first source. Will be describing about the retention.
Good afternoon, Commissioners. So I have been working with CPMC for about 5 years and on compliance, looking at their hiring from first source hiring in particular. And this past late spring, we were provided retention data. So I am on here to provide that to you today. So there were 277 hires over the 5-year period, and 128 of those hires were terminated, and 73 of those 128 were retained for 180 days. Now, 180 days is a metric that is used in the workforce development field. 6 months, obviously people don't, they come and go. There is a certain amount of churn, but 180 days is considered a good metric for retention. So given that there is 80% retention for that 180-day mark.
Would there also be an answer in regards to whether or not there were actually targets per neighborhood, or it was just that you took the listing of the neighborhoods from the development agreement and then just, added up where they came from?
Yes. So for the operations hiring of first source, there are target neighborhoods, and we do have the percentages and where the hires came from, the specific occupations that people were hired for. We do not have a goal of like 40% need to come from the targeted neighborhoods or anything like that provided in the development agreement. But I do have the breakdown for all the targeted neighborhoods if you're interested.
Well, I think we had the numbers that came from the targeted
That was for
neighborhoods already.
construction, and I do have it for operations as well. I can also tell you that from the targeted neighborhoods, I track all the referrals that are made from the community, and 57% of all the referrals that were given to CPMC come from the targeted neighborhoods.
Surely. Commissioner Burnell.
Yes, I'm just wondering, perhaps some of those numbers were misstated because by my calculation, it looks as though only 26% were retained for 80 days or 180 days versus I believe you said more than 80% and that 46% of the hires were terminated.
Right. So as I said, 73 were retained over the 180 days out of the 128.
Okay, and so then what was the 277?
That is the total number of hires over the 5 years.
Okay.
Okay. Well, thank you. I did have several questions which don't relate to hiring, so thank you.
Okay, Ken.
And they actually related, and for our planning commissioners, and we mentioned there were key healthcare issues. There were issues that were related to the fact that, as I think our staff had pointed out, that there was a recent hearing in regards to the changes where services would be provided. So perhaps the best example was the Diabetes Center, in which this was no longer a hospital-based service, but now would be moved over to the foundation, and the foundation itself was going to be the deliverer of those services. I think we heard, therefore, that apparently, if I recall from CPMC telling us that now in the foundation, when you go over to the foundation, we have language specific types of people, and so therefore this is better. The problem that the commission currently is reviewing and looking at is whether or not, because this moves those services from hospital to a private organization, that they would remain under the scrutiny of the city. And they don't, because then it would move over, obviously, into a private organization. So if you were wondering why that was of some concern, I just wanted to clarify for your information one of the key healthcare issues that we are struggling with now. It doesn't mean that it won't be better or that there can be more enhancement, but definitely the city would have far less influence over what kind of services these were and whether they would continue to be provided to the populations that historically the hospitals had served. And so while outside of the development agreement, it is a movement that is occurring. And it might be symptomatic along with the discussion that I think our staff pointed out, in which while, and to CPMC's credit, they are now caring for the subacute that were being displaced by the closure of subacute is absolutely true, as was pointed out by the staff and other speakers, that there are no new beds that are being created in this situation. And that while technically, and we can check mark that CPMC was greatly instrumental in assisting in the subacute studies that were, we still need to continue to respond to the need of the city to have subacute services, and that we continue to want to encourage that CPMC participate in that. That simply because they completed the study, I don't believe that while technically that could be considered in compliance, that should be the end of the relationship in terms of any further looking at a subacute solution for the city. We do recognize that it isn't one that CPMC itself has to come up with, but that they should be a part of this solution, and that just assisting us with the first level of study in regards to understanding the problem does not absolve either CPMC from having to continue to participate. I believe that it's my understanding that we are continuing to have dialogue with CPMC on this, so that I don't want to say that they just walked away and out of the door, but I'd like to encourage that we have continued dialogue in that, and also in regards to trying to resolve the SNF. Because as they have closed the SNFs, there have been no added beds, as has also been pointed out by the public, in regard to the SNFs. So we have kind of a conundrum here. Yes, they have complied with the development agreement, but there are a lot of areas in which then, while complying, we are losing services that are historically those that have either been delivered by the system and or historically serving a population within the neighborhoods. And if we had the opportunity to be able to continue to encourage that in the course of the remaining part of the development agreement, we could then continue to help influence and work together with this. And I'll have some final comments and later, after we conclude everybody's discussion, on what we would hope from our department that we would be able to do to continue to service the people of San Francisco and in collaboration with CPMC. So, Commissioners, I think at this point we should then hear from our planning colleagues.
Thank you. Commissioner Fong.
I thought the Planning Commission was complex. You guys certainly have a complex job, and appreciate it. I just wanted to maybe ask, after hearing all the public comment or the community input, if CPMC had some responses to some of them, maybe in particular the subacute care, if there was any reaction to that, or maybe things that are in the works that are addressing some of the community comments.
Specifically to the subacute care, as Commissioner Chow described, those patients have been transferred to the Davies campus and are in a new unit there, where the staff are credentialed and trained to handle those patients. In regards to some of the other thematic things that were brought up, we've got retention numbers here. I'm sorry for the oversight if that wasn't included in the submission packet. I think the notion of transitioning to these new hospitals, everyone can appreciate, is a complex and fluid process. And I think one of the examples that came up around orthopedics is a good example of understanding how physicians decided at that moment to move cases to a new location. So services that support that work also need to follow. We would have loved to have had that decision happen a year ago, 6 months ago, 4 months ago, maybe not exactly when it did, but that is when it happened. Our commitment to safe patient care, especially through these transitions, is the first priority. Thousands of hours of training and preparation have gone into this, and while I understand there are always going to be differences of opinion or concerns that happen when you get into that acute moment around the transition, our commitment is to absolutely quality, safe care transitioning these patients from one hospital to another. We do have people here who can talk about some of the HR issues. We have someone here who can talk about all the work that's going on to promote the transportation subsidy. But thematically, those were some of the things that I heard.
Actually, from the Planning Commission side, if you don't mind, just someone addressing a little bit about the transportation and through the entire network system, how
Sure.
that might play out or is playing out.
I'll have Rigo Hurtado speak to you about the comprehensive plans around our transportation demand management.
Thank you.
Sure. Thank you, Jim. Good morning, I should say good afternoon, commissioners, and good afternoon, Dr. Laura Green. It's been a while. If you don't mind, I'd like to give you a little background for where I came. I'm a San Franciscan for 50 years, and I've worked for CPMC for 41 years, and I'm very, very proud to have worked there, continue to work, and I have a tremendous amount of colleagues that are committed to CPMC. One of the areas that is complicated, and Dr. Green knows very well about it, is parking. So what we have done since last year in January, when we started the transit subsidy, we had put that information out to employees every month. On their paycheck, there's a biweekly communication letter that goes out to employees, is in the intranet. We hold 4 transportation fairs a year. This year, we're having 12 of them, which 4 of them were already completed last month, and the next one will be in October, and the final one will be December. And our push is to remind employees that the city first is to reduce the SOV. Now, when we got the survey returns, a lot of the employees' comments were that why they didn't take public transportation. Some of them claim that they work at night, they come on weekends, public transportation is not really available for them. A lot of the responses were especially with mothers, that they would have to pick up their kids right after work, so their time was consumed and necessary for them to go from one place to the other. I think we have made tremendous progress from last year. I believe that we're now about 850 employees that take this subsidy, and we continue, and we're committed to get that goal much higher. Another item that came in concern was that BART in itself, it's a scary for them to take that in Muni was a concern, but I know that the city is doing quite a bit of work to resolve those issues. And again, we're committed. Any other questions?
No, thank you very much.
Thank you.
Thank you. Commissioner Johnson.
Thank you so much. First, I wanted to thank city staff, CPMC, members of the community for coming out to share your perspective, and my fellow commissioners. I have just learned so much from you already, and like my fellow Commissioner Fong just said, this is a great kind of introduction into your world. So first, it's really great to see community agreements kind of played out in real time, and I'm grateful for this opportunity to be able to have a community conversation on what's happening so we can see what's working, what's not, and what we can do to make sure that we actually achieve our ultimate goals of providing excellent care to all San Franciscans. I wanted to touch on health disparities, which is an issue that I'm passionate about in relation to the report out on culturally and linguistically appropriate care. This was actually just recently in the news on several fronts. Yesterday, President Cohen announced a doula care program to protect mothers, particularly women of color and their children. In this city, Black babies are 5% of births, but 23% of infant deaths, and 13% of Black mothers, 10% of Pacific Islander mothers, and 9.1% of Latinx mothers have preterm rates, which is almost 50 to 70% higher than white women in this city. And that coverage alone has received national coverage specific to San Francisco. And so when we're talking about culturally and linguistically appropriate care, we need to be talking about racism, about stress, about systemic health inequalities, and equity as part of those conversations. Making sure that people can get care in their community, that it's affordable, and that you're working specifically not just in making sure that those populations get care, but that we're working on reducing bias both in the hiring and staffing processes, in our workforce, which is also diverse, and then also combating bias in the industry. I know that the CPMC Foundation was part of that doula care effort, which is awesome, and I'd love to see other efforts that you are combining with your workforce investments to really reduce bias in the industry, because we know that it goes from hiring to how the care is actually delivered. On workforce development, another issue I'm very passionate about, we know that it's not just enough to get people in the door. As my fellow commissioners have said, you have to create the conditions to help them thrive, and that requires tracking retention and creating programs and supports. So, when we hear that number of 277 folks hired over 5 years, and the number of 128 folks being terminated, that begs the question, as somebody who's worked in workforce development, of what's happening with training, with supports for those workers. I just looked up the average turnover in healthcare. It's about 26%, and those numbers don't mirror that. And I know that it's a different population, but I want to know what the average is in relation of the average of those workers are in relation to the retention of those workers. It's been a bit disheartening to hear about the LVN, the RN, and the CNA staff and talk about their working conditions. This population of the workforce tends to be diverse. They are also vulnerable and crucial to providing quality, holistic, culturally competent care. And so, I echo the concerns of the community that we want to better understand kind of what how you're supporting those workers and that staff. And then also, I wanted to address charity care patients, which I hope we can maybe come up with a different phrase for that. And really tracking where people are coming from in different zip codes, ethnicities, and their ultimate outcomes, and whether we're moving the needle on their outcomes, because that's what we're actually trying to get to. And if we're not slicing that data by race, by location, it's hard to achieve goals, again, if you're not measuring for that data. I agree with Commissioner Sanchez overall that I think that going to a deeper level of better understanding the data will provide all of us with an important opportunity to make sure that we're having impact, which is our ultimate goal. And even perhaps inform the city about what's happening in our workforce pool. Do people have access to good jobs? What are the best practices on retaining this type of workforce? And ultimately, we can all learn together what a world-class healthcare system looks like that makes sure that all San Franciscans have the highest quality of care.
Thank you, Commissioner Johnson. Commissioner Moore.
My singular biggest question is the discrepancy between two presentations in this room today, and this is not the first year that I'm saying that. There is a strong technology, managed data and result presentation, which looks fine, it's graphically convincing. However, the public testimony, including the questions that I associate with from the Health Commission themselves, seem to not fully substantiate the high success rate of the data as they're being presented. And then comes the public voice, which raises issues which go far beyond anything what a written word can communicate, and that is where I feel my primary questions are. I like to basically stand with the San Francisco for Healthcare, Housing, and Jobs and Justice questions raised about the 7 issues. You have those issues in front of you. I do not want to spend time going over them, but each and all of them, individually and together, matter and require further and in-depth examination, including the strong infusion of the human voices which testify to the fact that there is a big gap between the words and the deeds. The other points that I was raising as additional questions is, and I'm reading them off as I took notes. They're not necessarily listed in the order of importance, but I would say if I could speak at all of them at the same moment, they're all equally important. There is the issue of the Chinese hospital. There is a transition to new facilities and the lack of coordination and note-giving, preparation, and training. There is the ever important nursing staff testimony that I've witnessed now for the entire time that these two commissions have had a dialogue about CPMC and changes. There is a patient care testimony, which each of us could find ourselves in no time. And there is the hiring and job creation and retention issue. Those were the ones that I want to just briefly summarize and let them stand in the room knowing that they will most likely be echoed by all of us.
Thank you, Commissioner Moore. Commissioner Koppel.
Thank you again to all staff involved from all the departments, all the companies. Again, good to see the Health Commission here as well. I do have some multiple comments regarding to the construction side of this project. I'm not too familiar with the hospital operations side, but I'm familiar enough with the construction side. I'm an electrician by trade. Before I got into this position, while still working in the field, I worked at multiple of the CPMC campuses on California campus and Pacific campus. And then later on was fortunate enough to work on the building of the new General Hospital. And I clearly remember the day where I was proudly capable of filling out my local resident paperwork and photocopying my driver's license and submitting that in. And it's a big point of pride for residents to build their city and build especially important buildings like hospitals. We frequently see housing and commercial projects, but hospitals are a essential cornerstone to a well-functioning city, and it's something we take seriously here at the Planning Commission, and I'm sure the Health Commission does as well. I wanted to acknowledge both Ken Nim and Josh Arce with the Office of Economic and Workforce Development and their continuing efforts to keep CityBuild an extremely successful pipeline for all types of minorities from disadvantaged neighborhoods, parents with or without children, or parents are going to have children. And we're definitely keeping an eye on the increasing percentage of women in the trades, and also we're taking it to the next level within my trade specifically, something I honestly have nothing to do with,
but we've been noticing a higher acceptance of the LGBT community within our trades. And since this increase of diversity has created what's called the Electrical Workers Minority Caucus, which has, proud to say, has had a float in the Pride Parade for the past 2 years. So the building trades is really making a strong effort to diversify, to stay inclusive, and what we've been doing specifically with City Build to increase access to all residents is work out partnerships and deals. For example, a lot of people cannot pass the entrance exams to get accepted into apprenticeship programs. And so what we've done with certain specific trades is work out a deal with City Build where if you have perfect attendance and let's just say, for example, a B average, you are able to bypass the entrance exam and go straight to the interview stage of an apprenticeship acceptance process. So what that does is give access to a lot more San Francisco residents, 94124 and all the other zip codes, but it's just giving people a chance to reap the benefits of organized labor, healthcare benefits, prevailing wage. I'm up here today because I was accepted into a trade. I lived here in the city. I was interested in construction. It took me 3 times to pass the exam and actually gain acceptance into the electricians program. So it's no easy task for anybody, but the building trades and City Build are working tirelessly to increase the diversity of our construction workers and also the employees that work for the construction companies but off-site in the offices. So it's something I know we all take very seriously. Now if I could just kind of address some of the project-specific notes that I wrote. Exceeding a proposed timeline almost never happens. So this should not be overlooked. The fact that construction I always look at as organized chaos, and so many things are scheduled on top of each other that if one small thing goes wrong, the whole entire project's pushed back, sometimes months or years. And I have always kind of kept tabs on the CPMC project because, like I said, I was working in the field at General Hospital, and I was slated to go to the CPMC project. So what happened was there was this timeline of projects. There was kind of a 1, 2, 3 step where UCSF Mission Bay was the first one to begin, and then a lot of the residents from that job were supposed to, once completed, go to the General Hospital project, and then once that was completed, those workers, those residents, were supposed to go to the CPMC Van Ness and Geary project, and that was held up by about a year. So things were planned to work seamlessly, and those residents were supposed to stay working, but the holdup at Van Ness and Geary kind of, threw a little wrench into that. But I do know that speaking with the other trades, that they've been having either weekly, monthly or quarterly meetings with City Build, with OEWD, with Herrero Belt to make sure as many residents are working on this project in the office and on the job sites as possible. So 30% local hire, considering that this is literally the busiest times the construction industry has ever seen in their existence in over 130 years. 30% local hire for Van Ness and Geary and St. Luke's is absolutely in full compliance as far as I'm concerned. And again, I can't help but emphasize that this is a model project that ideally we could duplicate on other projects with more development agreements. You've got San Francisco contracting businesses building a hospital project in San Francisco, employing San Francisco residents that attend apprenticeship training centers in San Francisco. They're spending their money here in the city. The local businesses are paying their gross receipts and their payroll taxes to the city. Some people have said in the past that local hire and local contractors bring a higher cost to the project, but when you think about it, we're just reinvesting in ourselves, and we're paying people a high enough wage where they might be able to, like I did, stay in the city, buy a house in the city, stay here in the city, and not commute 4 hours each day. That's just the way I think it should be done, and this is the way it's being done on this project. So, again, as far as I'm concerned, from the construction side, in the office, and on the job sites, this project's in full compliance.
Thank you. Commissioner Bernal, did you have something to add?
Yes, thank you for the opportunity to just add. I'd like to speak to the responsibility of serving residents of the Tenderloin. I understand that this partnership is less than a year in existence, but when you look at the numbers, 180 versus a goal of 1,500, that's only about 12% of that goal. And when you look at the residents of the Tenderloin, serving them aligns with many of the priorities of the Department of Public Health. And I'll use as an example a presentation that we just received the other day about San Francisco's Getting to Zero initiative. San Francisco has succeeded in radically reducing the number of new HIV transmissions over the past several years, far outpacing the rest of the country. But we're about to see a leveling off now, and where we're seeing the new infections continuing to happen is among many of those populations, people who reside in the Tenderloin, people who are marginally housed or homeless, people who may be dealing with mental illness, people who use injection drugs. So it's imperative that we provide services to them, because the data shows not only that even if someone does become infected with HIV, that if they are able to be retained in care and get into treatment right away, it reduces and in many cases eliminates their ability to transmit HIV. So, and also data shows that being marginally housed or being homeless impacts your adherence to your medication regimens and other things. So these are communities that really need to be served, and we would like to see much better numbers in terms of the community members that you're able to engage in the Tenderloin through the partnership through St. Anthony's and NEMS.
Thank you. So I'm not going to repeat any of the other comments that my fellow commissioners have made. I think everybody hit every point that I had. With the exception that I do want to stand with the healthcare, housing, jobs folks, and one of the particular things that I would expect at our next time reviewing this item is a much deeper analysis in the areas where we're not hitting the numbers. I hear you that hitting the 30% in a time of all-time high construction is good. I wasn't satisfied with the level of analysis of the numbers that we were presented, particularly around the decrease in the numbers for the apprentices in year over year. So I would like a more nuanced analysis of why that's happening and what we're doing to rectify it. And under the purview of the Planning Commission, especially the public transportation benefits and what the plan is. We are seeing a dramatic decrease in car ownership in San Francisco, and my expectation of a major employer that has 43% of its workforce living in San Francisco is that those public transportation numbers would be higher. So I'd like to have just a deeper analysis presented of what we're doing about it and how we're going to see those numbers increase. So thank you very much for the presentation, and for staff. The presentation was clear, and for the members of the public who continually come out to keep tabs on this project, on making sure that the public benefits that were negotiated in the development agreement are being held. So thank you very much.
And so I would just like to also conclude with a few remarks, and what I hope we will also try to carry out some of our obligations from the Health Commission and the department to try to respond to some of the questions and answers. And clearly, in one area I did not actually get to go into, but also I think it's the same issue that we've raised here, is that while we can check the boxes, for example, under the cultural and linguistic standards, we don't really have an understanding of what those actually meant in terms of idea and analysis, I did a study, I did this, and what were the results and findings. To also then, I think coming back to that question, just as an example of perhaps the wrong tool, is if we're going to use people who came to the diabetes clinic at St. Luke's to find out if they were happy with the lack of a Spanish-speaking receptionist, that doesn't quite seem to capture the group of people that may not have come because they couldn't get understood. And so a different type of analysis really needs to be done if the question is, should there be that type of service? Of course, since it's now been moved to the foundation, I'm glad to hear the foundation has those services, but we would now, and that's another example of moving these services from the public side of scrutiny under our Prop Q to the private foundation, that we then really count on the goodwill of CPMC. So just to conclude then, what I have heard and what I believe that our department would be able to do to help respond to some of the concerns that both the public and our fellow commissioners have raised. I first want to indicate that I think I'm one of the members here who have been through this entire process from even before the construction started, because not too many people remember that I sat even on a Blue Ribbon Committee in regards to what to do with St. Luke's, and prior to that there was all the issues also of the rebuild, how big the rebuild should be, where the rebuild should be. And so it really is wonderful to see that a new facility for our community at St. Luke's and the Mission Bernal Heights area has been built. That is part of fulfilling the public-private partnership in order to have a healthier San Francisco. There is no way the public itself, the public side, can actually handle all of the needs that will create a healthy San Francisco to respond to the disparities that, as another example, St. Luke's has been doing, as Commissioner Sanchez pointed out. And the development agreement, in its spirit, calls for a continuation of that commitment to the city. And that while, yes, and it's wonderful that the project has brought $300 million to San Francisco, it's not without the need also to continue to remember the obligation then that as a nonprofit hospital, and even just using the historical basis, which is why so much was written into the development agreement, to try to be sure that it would not just be a facility to treat those who could afford it, but to be able to participate with us. And I want to acknowledge that I think that CPMC has been working with us. But you know, it seems that we always have to actually keep asking for that to happen. And it would be so much nicer if, in fact, we had a willing, proactive collaboration. Even at our commission meetings, when we are looking at the potential of changes, it takes almost that public hearing in order to make some of the accommodations that were needed in order to respond to the needs of our residents. I found that the Sutter model of we and you was very interesting, because I think at the moment, from what we can hear in the testimony, there's a lot of we and very little you. And instead, I'd suggest to CPMC that we could have a true we and you if we really didn't look at this as we versus you, but that we really should be we and you. There's an outreach to the community that really is needed, continues to be needed, and along that line, we as a department specifically would be looking at the issues that I believe the coalition has raised validly and has been also brought up by all commissioners here in terms of, we're going to only look at the health side. we'll leave you to look at the workforce and all. But I believe that we will ask our staff to actually try to look more in depth into understanding that not only is it technically done, but what was done. And I commend, for example, the San Francisco Foundation report that's in here that showed you what was done when they received the money, who actually got help and how that happened. I think it's also important that we try to assist CPMC further in trying to find where the issues are about St. Anthony's and the Tenderloin. That this seems very unusual. It's been more than a year that this has happened, and we only have this small uptake. I think suggestions have been made. Is it transportation? Is it access even at a primary level? Well, I would say that our department does have a interest in this, and we will review this again and try to see if we can also continue to be helpful in the partnership that has been put together. Again, the Center of Excellence is certainly something that we would all be concerned about. And that would be something that we'll ask our department to assist with, working with CPMC in terms of understanding where the issues are. Dr. Barnes has also outlined his vision. Obviously, the vision is one that needs to be developed by CPMC. But I think the consideration is a very good example of working with the community would get a far better acceptance, and I think maybe even a far better product that meets the needs of the residents who are in that community. So in conclusion, our department does continue to be eager to work with St. Luke's, not just St. Luke's. I'll get the new name one day. But with CPMC and Sutter, you're a very important part of the city. Sutter is with the assets that could be also continue to be placed to great use so that we can continue to enhance the public-private partnership that we've been enjoying between all the hospitals and providers in San Francisco with the public sector as we achieve our goal to improve the health of all San Franciscans. So I do want to thank everybody who participated, the staff who did such a hard work in analyzing this. But I think that in our next review, I believe that we've heard that a lot more detail should be also provided to understand what happened after the check mark. So thank you.
Thank you.
Commissioners, that concludes your agenda today.
Thank you.
It's wants to make a motion to adjourn?
Move to adjourn.
And I so move. Also.
Second.
So should we come back at 1:30?
Yeah, for those members of the public who are here for the 1 o'clock meeting of the Planning Commission, I imagine the commissioners who have been here will want to take a quick lunch break. So we will probably convene it no sooner than 1:15.
How about 1:30?
1:30?
Yeah.
Very good.
Thank you. Hungry.